Hello, everyone, and welcome to our 2025 PKD Summit. My name is Michelle Lynn Goodfellow, and I'm the Communications and Engagement Manager for the PKD Foundation of Canada, which is the only national organization solely dedicated to fighting PKD through research, advocacy and awareness, and education and support. This session is a presentation by fertility specialist Dr. Nickan Motamedi. And we will have a live question and answer period at the end of the event if you'd like to put your questions in the Q&A area or in the chat. This session is being recorded and will be available to view on our YouTube channel in the coming weeks. So I'll now introduce Dr. Motamedi. He is a reproductive endocrinologist and infertility specialist at Trio Fertility in Toronto. He has published and presented research at national and international conferences and conducts research in infertility. He has worked with PKD patients to secure funding for IVF with preimplantation genetic testing for monogenetic disease, which is also known as PGT-M, for affected couples. Dr. Motamedi is a strong advocate for patient-centered care and decision-making in modern fertility care. So welcome, Dr. Motamedi, and we're looking forward to hearing about family planning with PKD.
Awesome. Thank you so much for the intro. So I'm Dr. Motamedi, and I'll jump right into it. Today's presentation should be about half hour or so. And as she said, I'll be taking questions at the end. So, I mean, this is a picture of me, maybe 10 pounds heavier, hopefully. But the only credential I want you guys to know is I'm a fertility specialist. I run IVF cycles. I work with patients who have genetic conditions that are monogenetic, meaning it's like one gene mutation. And for these patients, we have this technology, IVF with PGT-M, that can help them build a family and not have to worry about passing their condition down to their children. For more information, I worked with the PKD Foundation of Canada to build a web page for more information about it. So that's something you guys can access later as well. So today I want to talk about, these are the topics we'll cover and we'll kind of go through it. I think most people on this call, as I understand, know about PKD and the inheritance pattern of it. So I'm going to go through that quickly. And then I really want to spend most of our time talking about IVF with PGT-M, because the feedback we get is that when it's accessible and when it's an option for people, it's something that they like to do and that they're really grateful for. And it's kind of where my expertise lies. So that's kind of the purpose of today. I want to cover everything though. So very briefly, autosomal dominant and recessive PKD are the two forms of PKD, and over 90% of patients will have autosomal dominant PKD. So that will be the focus of my presentation today. It's much more common. And so that's when one parent has a bad copy of the PKD gene. And so then they subsequently have PKD. And we have two copies of each chromosome. So this is a kind of an image depicting a couple. And you can see the affected parent has one copy that is affected, and then the white is a copy that's not affected. And there's a 50% chance that a child that they have inherits the bad copy. And so there's a 50% chance that a child would inherit PKD as well in the dominant form. In the recessive form, which is less common, you have two parents, which each have a bad copy, but because it's recessive, they're not affected by PKD. It's only if a child inherits both bad copies that they would then be affected. So what are your family building options if you fit into one of these two cases? Let's talk about natural conception. So this is the obvious one. So just like anybody else, you can just conceive naturally. So the female partner, and I should say, I'm going to tailor a lot of this presentation to heterosexual couples. Of course, for same-sex couples, we have options as well. That'll be included in the presentation. But because most of the couples we see coming to us really present as a heterosexual couple looking to work the sperm and the egg together, the donor situation with that homosexual couples face is kind of a separate concern. So I'll touch on that as we go through it, but just briefly, for heterosexual couples who want to conceive naturally, the female partner should be having regular menstrual cycles. And I would always recommend using these cycle tracking apps. as a fertility specialist. They tell you what your optimal intercourse window is to get pregnant naturally. I would also recommend using ovulation predictor kits for your own sanity. It will tell you the exact days where your odds of success are highest. And then the big takeaway I want you guys to know is that, it can take several months of trying, and that's normal. If you have irregular cycles, or if you have complicated medical conditions, or you're worried that the male partner in the couple may have an issue because they've used testosterone or anabolic steroids before, you should consider an early assessment by fertility specialists and not wait too long before getting checked out. If you're under the age of 35, we recommend waiting 12 months of trying. And if there's no success at that point, then getting checked out. If you're over the age of 35, 6 months or more, and you should probably get checked out. So as we've already touched on, the odds of having an effective child are about 50% in the autosomal dominant form and 25% in the recessive form. So when you conceive naturally, you're kind of at mercy you're at mercy to the statistics. And there's things you can do to find out and get a sneak preview on if your pregnancy is affected by PKD. So I want to just clarify though, regardless of where you are in the country, there are screening programs in pregnancy that are broadly labeled as genetic testing, okay? So I've labeled EFTS here. This is the one we use in Ontario, or MSS, which is used elsewhere in the country. But invariably, they involve some form of ultrasound plus blood work in the first trimester. There's also NIPT, which is a blood test after 10 weeks that usually you have to pay for, but some territories will actually cover it. The key is these are genetic tests, but they check for Down syndrome. They do not check for PKD. So not all genetic testing is the same. What you really need is what's called CVS, chorionic villus sampling, or amniocentesis. These are covered by your provincial health plan, and they will specifically check for PKD mutations. They're done either late in the first trimester or later on or early in the second trimester, and they provide diagnostic information. So pretty much 100% accuracy, so that you can know what's going on in your pregnancy and if your child has inherited one of these mutations or both. You can also, this is not a great option, but one other thing you can do is wait for your anatomy ultrasound. The anatomy ultrasound happens kind of halfway through the second trimester, around 18 weeks. And it's also covered by your provincial health plan, but it rarely detects signs of autosomal dominant PKD. So that condition just doesn't really show up in the fetus when we look at the kidneys on ultrasound. That's something that really you would need amniocentesis or CVS to determine. This is kind of like pictures of what it might look like. I know it looks very scary, but essentially there's an ultrasound. You get freezing, so you don't feel any pain. And they go in with a this is a much wider needle than it actually is. It's extremely thin and you don't feel it. And it goes all the way and it samples part of the placenta. You can also go through the cervix depending on where the placenta is. And with amniocentesis, it's the same idea, except instead of sampling the placenta, we're sampling the amniotic fluid because the fetus releases skin cells into the amniotic fluid. So we can sample those, sample the fetal DNA, and run an analysis to see if it inherited any PKD. So the pros of this option, natural conception with prenatal testing, it's natural, it's free, it's accessible, it's fast. The cons is that you have no control over the inheritance. It's the 50% for dominant. It's the 25% odds for recessive. And then when faced with those odds, you need to decide if you want to do any testing to see if your child has inherited PKD. And if so, you would need to decide whether you want to terminate or not, which is obviously a very difficult decision. With prenatal testing, as I said, it's covered by the government. It's 100% accurate, and it allows for control. But it doesn't prevent the inheritance of PKD, and then choosing to terminate again is kind of a difficult decision. Let's talk about donor material use now. When I'm talking about donor material, I'm talking about using donor sperm and donor egg. So this is kind of where this is a more aggressive option, I would say, but provides certainty. So if it's the male partner in a couple that has PKD, then you would use donor sperm. And what that does is when you pair it with an egg that is not affected by PKD, it gives you 100% certainty that the embryo and subsequent fetus and child will not inherit PKD. If the female partner is the one who has PKD, then you would use donor eggs. And then that, again, ensures the same thing when paired with sperm that is not affected. You can use known donor or anonymous donor. So a known donor would be a friend, a neighbor, a good Samaritan, somebody that you know. And an anonymous donor is using a sperm bank or an egg bank where the identity of the donor is anonymous, but you will know details about them, and we'll go over that. So using donor eggs or sperm eliminates the risk of having an affected child. But the downside of this, obviously, as you might be able to tell, sperm bank usually costs $2,000 to $3,000, and that allows for multiple IUI cycles. IUI is quite straightforward. What we do is we monitor the female patient for their natural menstrual cycle, and we wait until an egg is about to ovulate. We monitor with ultrasound and blood work, and then once it looks like the egg's about to pop out, what we do is we inject the donor sperm right into the uterus and to the fallopian tubes. The studies show that you have about a 10% odds of taking home a baby with each attempt at this. So usually people go into it expecting to need to do multiple rounds. And because it's not very laborious, it's something that you can do like 3 or 4 months in a row and not feel like it's too arduous or difficult. Each IUI attempt usually costs $600 to $1,000 or so. It varies by clinic across the country. It's not very invasive. It's not very difficult. It is ultimately somewhat more natural across the options that we're going to discuss. With IVF, this is the other option with donor sperm. IVF is much more expensive. I've quoted here about $25,000, but again, it varies. And that's without any funding if you have to pay for the whole thing out of pocket. It's 2 weeks of active treatment with injections daily. And then what happens is we extract the eggs out of the ovaries. The injections are done to create a lot of eggs, and we call them follicles as they're growing in the ovary that month. And then we retrieve them all out of the eggs in a sedated procedure. And then in the lab, we combine the eggs with the donor sperm to create embryos. The embryos are then transferred one at a time, and then basically until you get pregnant. And the success rate is very high if you're age under 35. This is actually the success rates across Canada. I think I would draw your attention only to this orange bar chart here. You can see it's very dependent on the age of the female partner. So this is the age categories down here. You can see if you're under the age of 35, you have over 50% chance of success from a single cycle. And I would actually say these odds are underestimated if you're significantly under the age of 35. So if you're 30, it's probably closer to the 60 to 70% range. And this is nationwide. Let's say the female partner has, PKD, and so you're considering using donor eggs. IVF is if you want to use donor eggs. So you may use, again, a known donor, so like a sister, for example, or an anonymous donor from a donor egg bank. This is a picture of what the landing page might look like, so similar to the donor sperm. It gives you a lot of information. Race, ethnicity, eye color, hair color, height, education level. It's actually a little bit scary in some ways. It's almost like Amazon shopping. But you do get a lot of information. And then how it works is you would just order the eggs. It gets shipped to your fertility clinic. We at the fertility clinic in our embryology lab will thaw the eggs, pair it with your sperm provider, so your partner, and then create embryos. And then those embryos are transferred into you. So I think it's important to know that the female partner, even if the female partner has PKD, they can still carry a pregnancy even if they use a donor egg. Obviously, this is assuming normal kidney function. If you have really end-stage PKD and your kidneys are unhealthy, your OBGYN may recommend not getting pregnant because it would put you kind of at risk. So in summary, I would say donor material use is one of the lesser common options for patients with PKD, but it is an option. Donor eggs and donor sperm are viable. This strategy 100% eliminates the risk of a child inheriting PKD, but the child obviously will not be genetically linked to that parent. The options include IUI if you're going to use donor sperm, and IVF. And same-sex couples will often go to this option to conceive anyway. And if it's two female partners, you can use the eggs from one partner and it can be carried by the person the pregnancy can be carried by the person who has PKD. That's called reciprocal IVF. So that's something we can do. If we're going to use donor sperm to do IUI though, then it would have to be in the partner who doesn't have PKD. So that's how that would work. IVF with PGT-M, I think this is the main reason I'm giving this talk today, is kind of to explain this relatively new technology that we have. So how does it work? Well, we develop embryos using IVF, as I've already touched on. But we actually have the technology to biopsy the embryos now and analyze them genetically using a biologic probe that can be developed using a cheek swab from the person who has PKD. So it's exactly as I said, using a cheek swab, it picks up some cells that are in the mouth, and the genetics lab can analyze those cells, identify the exact PKD mutation, and then when they receive embryo biopsy samples, they can analyze those samples and determine this embryo has PKD, this one doesn't, this one will, this one won't, and that informs families so that they can decide which embryos to transfer. They can then transfer the embryos that are not affected by PKD. So again, how it works is it starts with an ovarian stimulation plan. So this is the injections at the beginning. And these injections make it so that the person who has ovaries is going to create a lot of eggs. Those eggs are then extracted, and in the lab, we pair them with sperm. It will then develop into embryos after fertilization. We then biopsy those embryos, and I'll show you pictures in a moment. We then freeze the embryos, wait for the genetic testing results to come back, and then do embryo transfers based on the genetic testing results. This is a sample of what it might look like if you're doing an IVF cycle. So it's about, in this example, about 10 days of injections. And then there's a day break, and then your egg retrieval day. So that's your sedated procedure. You can think of it like a colonoscopy or a dental procedure where you receive sedation. You're kind of asleep the whole time. And using a transvaginal ultrasound and a needle, they're able to get all these eggs out of the ovary. So once in the lab, we do what's called ICSI. So that's taking the best looking sperms and injecting them into each egg. And then it develops into a day 5 or 6 embryo. It takes 5 or 6 days to culture the embryos, and you get what's called a blastocyst. This is just a fancy name for a mature embryo. Just pointing out some anatomy here. So this clump of cells in the middle here is called the inner cell mass. So this is what actually turns into the fetus. And this outer part is what turns into the placenta. It turns out there is way more of this than is actually needed in humans and in mammals in general. So we can take a sample of this. It actually doesn't damage the embryo, which is kind of amazing and unbelievable. But the amount of evidence we have of this is like overwhelming at this point. So biopsying the embryo does not actually harm. And we then freeze this embryo, which is also safe, send the biopsy for genetic analysis. And you'll notice here it says PGT-A, not PGT-M. So the M component is where they look for the PKD mutation. The A component is looking for euploidy or aneuploidy. So this is two fancy words I'm going to introduce to you. Euploidy means this embryo has the correct number of human chromosomes. This term, aneuploid, means that the embryo has the wrong number of chromosomes. So humans have 46 chromosomes. In aneuploid embryos, it's got 47, it's got 48, it's got 43, it's got 45. Regardless, we know that if it's aneuploid, it has no chance of leading to a healthy child. So this becomes a game of banking as many euploid or normal embryos as possible. This is a picture of a very lovely, beautiful, high-grade blastocyst or embryo. This is how we do the biopsy. So we're taking a sample of what's called the trophectoderm here. So at the beginning, the first part of this process is we run the genetic analysis for PGT-A. So this is an example of a report. So this patient got 1, 2, 3, 4, 5, 6, 7 embryos. Okay. So of those 7 embryos, 4 are genetically normal. And I'm not going to talk about mosaics today. But effectively what you need to know is that there's 4 normal here. Okay. For this patient, that's probably enough. So once you feel like you have enough euploid embryos, and that's something you'll discuss with your fertility specialist, you guys will decide whether you're ready to do the M analysis or the PGT-M analysis to assess these euploids for PKD. If you don't feel like you have enough, like let's say you do a cycle, you only get one euploid, then you would probably want to do another cycle to get more. Because remember, some of these euploid embryos, while they have the right number of chromosomes, it may be that some of them inherited the PKD gene mutation. So we know not all of them will be good. In this example, they run the PGT-M, and it turns out 2 of the embryos inherited dominant PKD, and 2 of them are not affected. So the plan going forward would be to transfer the not affected embryos. It's also important to know that each embryo that's genetically normal is not a guarantee to lead to a child. So each one has about a 50 to 60% chance that you take home a baby after the embryo transfer. So obviously then the game becomes getting as many euploid embryos as you can and hoping that the genetic kind of stats component of this, which is that 50% of them will be affected and 50% will not, kind of fall in your favor so that you have as many transferable embryos as possible. Obviously, the advantage here is if this first embryo transfer works, great. Now there's one in storage for if you want a second child as well. So after you get your PGT results, you proceed with embryo transfers. As I said, each usable embryo has about a 50% odds of leading to live birth. If you have other usable embryos remaining, they're really frozen in time. So the success rate of an embryo transfer 10 years later is the exact same if it's frozen using modern techniques, which in Canada, I'll tell you they all are. Clinic storage fees are usually not a huge issue. $50, $60 a month is kind of typical. And if you've completed your family and you're done and you have some remaining embryos, you can have them donated to research or have them be discarded. Those are really the 2 options. Kind of other information here is the odds of success are similar to the previously quoted IVF success rates and costs. I would say it's very age dependent, as you saw with that bar chart. And I would say PGT-M patients are likely to need more than 1 cycle compared to the average fertility patient because some of their embryos are not usable as a result of, inheritance of the gene mutation. Really, the reason why a lot of people like to go with this option is obviously not because they want something aggressive, invasive, and expensive. It's because this is really the only intervention we have that selectively prevents conceiving a child affected by PKD and also preserves the ability for you to pass on your genetic material. PGT-M has been, popular for about a decade now. We do it for all kinds of genetic conditions. BRCA, which is the breast cancer gene mutation, cystic fibrosis, sickle cells. These are all conditions that you guys have heard of. And they're very common for these indications. IVF with PGT-M, according to our Canadian stats, accounts for about 7% of all IVF cycles in Canada. So this is really common, as it turns out. The cost is the same as with other IVF cycles, but there's an additional $3,000 to $4,000 cost for the PGT-M component. So in total, you're looking at about $30,000 a cycle. If you're scoffing at that figure like I am, I have some slides about funding in a moment. One second here. Okay, so I don't recommend IVF with PGT-M for everyone. So for patients where for couples where the female partner is over the age of 40, it gets a lot harder. Why? Because it's harder to come across euploid embryos at that age. Also, if you're in a non-IVF funded province, or if you have limited financial resources or time resources, that can make things challenging too. If your egg count as a female partner is low, that can make things challenging and can increase the number of cycles that you might need. And if there are other fertility issues, that can also make this not the best fit for you as well, potentially. The bottom line, actually, I would argue if there are some fertility issues, make it a better option. Some fertility issues make it a worse option. But the bottom line is you should always get an assessment of your odds of success and expected number of cycles and a ballpark estimate by a fertility specialist who does this. Let's talk about IVF funding in Canada because this thing is really expensive. So I developed this and it's on the PKD Foundation of Canada's website. But basically, every province has a different funding plan for IVF. It's actually updated a bit since I had this uploaded about 8 months ago now. So British Columbia has established their IVF funding program and you get 1 funded cycle that's covered. In Ontario, you get 1 funded IVF cycle as well, but it excludes medications. In Quebec, it does include medications and you get some storage costs covered. Other provinces give you grants, subsidies, tax credits. There's a whole array of options. And there are a few provinces and territories that don't have any funding available. So unfortunately for them, for those patients, there's not as much in the way of options. There's also this charity, which is called the PKD Free Alliance. This is an American charity, actually, that has a mission of ending PKD. And I was able to reach out to them and find out that they do have a grant for couples who have PKD looking to expand their family and have children. And they will pay for the PGT-M component of your IVF costs. So I think that's helpful. Again, it amounts to something between $3,000 to $5,000. And a little bit is always better than nothing. So to summarize, I think the sources of funding, obviously there's self-funding, but there's government funding for most people. The PKD Free Alliance in the US. Private insurance and benefits through work is really important, guys. I've had patients in the past, not a lot, but there have been some who spent tens and tens of thousands of dollars. I had a patient who spent over $100,000 once doing 5 different IVF cycles. And then they came to me as a kind of second opinion consultation. And we dug through their insurance and found out they actually had coverage the whole time, but they had spent their money over the past several years and were no longer eligible to get any of that covered. So please, please, please look into any work benefits that you have. Increasingly, private insurance plans through Manulife, Sun Life, Canada Life, Blue Cross, like they're starting to add IVF coverage. So that's definitely something you want to look into. Also talk to an IVF clinic about financing plans. Sometimes there's discounts. Like if you're somebody who's going to need more than one cycle, they can sometimes shave, a couple $1,000s off, and that matters, right? So this is a bit of a passion of mine. I think that's all the slides I have for you guys today, and I'm happy to take questions.
Awesome. Thank you so much, Dr. Motamedi. So we now will take some questions from those of you who are joining the call live. If you want to put your questions in the Q&A area or in the chat, we'll get to them. I see that there's already one in the Q&A area. This person did not get ADPKD from either of their parents. They were a spontaneous mutation. But would all the information still be the same for this person's family planning?
Yes.
So they, yeah.
So it turns out that the inheritance doesn't actually matter for your case. If you have we call it a de novo mutation. So if it's a de novo mutation, all of this still applies to you. So you can still do IVF with PGT-M, and you're still kind of at risk of passing down your de novo mutation onto your children. There's a 50% chance. Yeah.
Awesome. And we have another person asking, does the provincial funding of IVF include the new testing method that you mentioned?
No, so that's kind of the problem, is that the genetic testing is not covered in the provincial funding. In Ontario, in BC, and I believe in Quebec as well. And the other provinces kind of have less funding, so I'm assuming not them as well. That's why I really like that the PKD Free Alliance is willing to provide some funds for the genetic testing component. I think in total, when you consider the PGT-A, so checking if the chromosomes have aneuploidy or euploidy, if they're genetically viable or not, and then the M, checking if they have PKD, those together make up probably between $5,000 and $10,000 of the like $30,000 cost that I quoted you on average. And so to get like $5,000 from a charity actually goes a long way to, bringing that cost down.
That's awesome. And did you confirm with them that grant is available for Canadians as well?
I can do better than that. I've had 3 patients who actually have already received their money, went through PGT-M cycles with that money.
That's awesome to hear. We weren't aware of that. So that's something else we can share with potential patients looking into this. I don't see any other questions from live attendees, but I do have some questions that are ones we occasionally get from parents looking to plan a family or start a family. Um,
Sure.
uh, Once I had someone asking about whether we knew if a fertility clinic's labs were located in the US or in Canada, and
Mm,
should that make a difference? And what should we ask um, the fertility clinic
yeah.
when we meet with them?
That's a really good question. So it turns out the embryology lab for your clinic will always be in Canada. So where you do your egg retrieval and where they actually create the embryos will be in Canada. The genetic testing lab is often in the US. I believe there's only one, there may be two clinics in Canada that have their own genetic testing lab and they run it in-house, but it doesn't actually provide meaningful benefit over the others. Why? Because I've been to those clinics. Their wait time for getting your genetic result is the same. Um, I'm not sure why that is, because that feels like the whole point is that you can shorten the wait time. Usually it takes 2 to 3 weeks to get your genetic results anyway. You're not waiting that long. Um, what I will tell you is the quality of the genetics labs matters. So I mean, I'll tell you personally, I would go to a clinic that that has some proven genetic lab results. So that means any clinic that uses one of the big players, iGenomics, Cooper Surgical, or my clinic uses Juno Genetics. They publish a ton of research about their accuracy and quality of their genetics lab. I think that works well. You can always ask in a fertility consultation what the genetics lab is that that clinic uses. And I'll tell you, in Canada, majority of clinics, it should be almost all of them, are using one of the big players. So I feel good about the reliability of the genetics labs. I don't think the genetic testing, the genetic lab that runs the analysis has to be like on site. Like, I don't think that matters.
Hmm. We've had a question come into the chat. Someone's asking, do the injections for IVF affect patients with PLD from a hormone perspective? So you may not be aware that many patients who have PKD also have polycystic liver disease, and majority of those are women, and it seems like the female hormones may have an effect on increasing the disease progression of PLD. So will the IVF hormones affect that?
So they will and they won't. First of all, if you have significant PLD, we usually we have a discussion with usually it's a hepatologist. Or an internal medicine specialist. So we usually have a discussion with them and make sure that you're safe to proceed with IVF. And it's really going to determine on your liver function, not so much the amount of cystic change that you've had. If the liver is functioning fine, then it's usually okay. What we do is we kind of tailor your IVF protocol to that history. So one thing that we do is we'll add a medication called letrozole that lowers the estrogen level that your body will see as you go through your IVF cycle. Why? Because estrogen is really the hormone that's going to affect the liver the most. And we do this for a variety of conditions. So for example, if you also have a history of endometriosis, that's a condition where estrogen really flares it. And so for those patients as well, we give them letrozole. We find that they have way better symptom profiles. And so this should apply to other organs as well that are estrogen sensitive, like the liver. So that is one example of the types of changes we would make in somebody who has PLD. So you're by no means excluded for having that, as long as you have a general bill of good health otherwise. So, patients who have uh, um, really severe medical problems otherwise, non-functioning organs or um, are a very high anesthesia risk, we can't actually get them sedated easily for the egg retrieval. And so that's kind of the type of person who would not be eligible. But if you're somebody who is allowed to receive anesthesia because your liver is functioning okay, then you are absolutely a candidate for this.
Awesome. Another question I sometimes hear is, what can people expect on average in terms of the number of transplantable embryos they might get
Mm,
with one round of IVF, or do you even
yeah.
give those numbers?
I give them routinely before you start, but it's so individualized to the patient. I didn't touch on it in this presentation, but it's really dependent, if you're the female partner, on your age and your egg count. And the younger you are and the higher your egg count is, the better your prognosis, the more likely you are to get more transferable embryos. And there's no way to kind of get around that. IVF works by overcoming the age problem by getting a lot of eggs. But if you're older, but your egg count is also low, it's like we can't get as many eggs from each cycle. You end up having to do more cycles. I will say, like, I know a patient who had to do 3 or 4 cycles because of a low egg count, but was ultimately successful. So it really just hinges on their motivation, their access to the financial resources and these funding sources that we've talked about today, and what their clinic was able to do and work with them on. But there's no way around that. That your biology is kind of a really important piece of this. And so the only way to know what your egg count is to get checked out at the fertility clinic.
Thanks. There's another question come in the Q&A. They're asking, does the severity of my PKD influence how severe my potential children would have the disease? So when they're
Yeah.
trying to weigh the odds and, of doing it.
So so I will say that is an excellent question for a nephrologist who specializes in genetic inheritance of kidney disease, or like a genetic counselor, geneticist. I'm probably not the best person to answer that question, but I will tell you, having had a lot of patients with similar questions, the answer comes down to we don't know. Oftentimes, there are some cases I've had where people have a rare medical condition and a genetic condition, and the feedback has been that, hey, yours is very mild. With this particular variant, we know that it passes down in a mild way, but that's not always the case. Sometimes it's something called penetrance. So penetrance means two people can have the exact same mutation, like genetically identical, but one person has a very severe manifestation and the other person has a very mild manifestation. And it's just that sometimes the genes penetrate through and show themselves in different ways. And it's unpredictable whether the way that it penetrated for you will be the same as it penetrates for your child. Whereas for other people, we know that there's some mutations that will always be mild. And so that's why it really depends on the opinion of like a geneticist who's able to do the research and look into your specific mutation. Your fertility clinic actually probably won't be able to help you with making that determination. That's something that probably has to happen from a genetic counselor or geneticist beforehand.
Thanks. I see that there's a question come in on the chat, and I can answer this one. The person's asking, what are some postpartum complications that can happen as a result of PKD or PLD? And what I will say to that attendee is we actually are having a session on pregnancy with PKD tomorrow. So if you have registered for that already, that's a great question to ask Dr. Zalam and Podemau tomorrow. And if you're not registered for that one, I can make sure that we bring up that question with them. We also have another question in the Q&A. They're saying, I'm 25 now. Does my risk increase regarding egg count and fertility if I wait until I'm 28 to 30? Would I be at a better place now than if I were to wait?
Yeah, so it turns out we've kind of mapped um the odds that you get good embryos by age. And 25 to 30 is fine. That's actually your peak, where the quality of the embryos that you would produce is actually best. Strangely, when you're under the age of 25, it actually is slightly worse, and we don't exactly know why that is. But 25 to 30 is the sweet spot. So I'm gonna tell you, there's no rush. I would not marry the nearest person. Pick your partner wisely. And if it's age 28, that's fine. Like, it's not a big deal. If it's even 30, I'm gonna say it's no big deal. What I would say is maybe know what your AMH is. I think it's useful to know. If your AMH is very high, then that's good. If it's even average, I would say that's good, because between 25 and 30, the AMH doesn't tend to change too much. It tends to change a lot more in the 30s, although it is different for everyone. And if it's very low, then it does inform you that maybe something like egg freezing is a good idea early on. But I wouldn't rush to do anything at age 25. I think you do have time. It's reasonable to just get one of those fertility checks. Many fertility clinics offer them. Just check your AMH out and see where you are on the spectrum, and if egg freezing makes sense for you. It also is relevant to know how close you are to conceiving. So if your timeline really is you have a partner, you really think age 28 to 30 is when you're going to be looking to conceive, I think it's also reasonable to do nothing and just wait until then. I think that's actually probably just the best way of going about it. What I'm more referring to is if you're single, you're 25, and you have no prospects right now, it's worth just knowing where you're at and getting checked out.
Thanks. We have another question. Does the age matter also if the father is the one with the ADPKD?
It does. So the age of the male partner doesn't matter. It's still the age of the female is what matters, even if the male partner is the one with PKD. So the person who has PKD actually is like a minimal problem if you're going through IVF with PGT-M. The female partner's biology is really the determinant of how easy it's going to be to do and how many cycles you're going to need to do and how straightforward it's going to be. We know that whether it's the male or the female that has PKD, 50% of the embryos are going to get PKD. That's just statistically how it goes. So the age of the female matters, the age of the male doesn't in that specific example.
Awesome. Another question I get is, and I know you mentioned this in the resource that you put together for us for our website, is would it be a good idea for the parents who are looking to start a family to think about what choices they might want to make if they find out through amniocentesis that they have a child with PKD, or if they find out that they have embryos with PKD?
Look, there's no right answer to this. I do think it's a good idea to have a plan and to think in advance. It's just really hard when you haven't been in that position before too. So I think it's good to have a good idea. And I think it's good to have a position on it, but I would always just keep an open mind. I have a couple who, went through this process. And actually, I know on the website, there's some testimonials as well of couples who've gone through this. And they were saying that, and they really stuck with it. They had to do multiple cycles, but because there was other fertility issues that kind of got in the way too. But they were kind of stuck because they were like, on one hand, we don't want our child to go through the suffering that, in this case, it was the male partner who had PKD. He's had a lot of medical challenges in his life as a result of the condition, so he doesn't want a child to have to go through that, which is very understandable. But at the same time, having to terminate a pregnancy, where your child is affected, it's like, that in some sense you wonder, like, that could have been me in a way, right? So it's a very emotional and difficult conversation to have with your partner. I will tell you, in the medical space, we know that it's a difficult decision and we have no place in it. That's a decision between you and your partner. This is, from our perspective, it's a medical procedure. It's termination for pretty much any reason that the couple decides is acceptable from the doctor's perspective. So there's certainly no judgment on our end. I'll tell you, we've seen everything, every reason under the sun. So there shouldn't be any guilt involved. I think it's really where you guys, you have to turn inwards as a couple and kind of make a group decision of what you're comfortable with. I think like I said, it's good to have a position on it, but it's, it is also different once it's real, if that makes sense.
Yeah, it absolutely makes sense. Another question I sometimes get is, because I personally know some parents who have gone through IVF, for various reasons. Is it a good idea, or does a fertility clinic help guide a patient towards any mental health care? Because the whole, IVF cycles and trying to find viable eggs can be a really can be tough.
Yeah. So, the mental health aspect of fertility care is well described. And there's actually organizations that offer counseling services just for fertility patients and couples going through fertility treatments and who are having trouble building their families, whether it's recurrent miscarriages, whether it's IVF failure, whether it's a long duration of infertility, again, whether it's relationship issues that have come up as a result of a fertility struggle. I'll tell you the most popular one out there is Bria Health, Bria, BRIA. You can look them up online. They're kind of a leader in this space. Our fertility clinic actually has in-house counselors, and I know many other clinics have in-house counselors too, who see patients at the clinic. Usually at least 1 or 2 appointments would be free of charge to speak with those counselors. And obviously insurance benefits will often cover those appointments. And yeah, the feedback I get is that it's really helpful and positive. And I mean, the challenge is in my position, I have the privilege of offering these as options. And when it works, it's like priceless. When it doesn't work, it can be heartbreaking. And I see both sides of it. And so there is support from that end of things. Um, but yeah, either in-house or externally.
Um, and I don't see any other questions from live attendees. I have what may be a kind of unusual question out of left field, but we are having a session as part of the summit tomorrow about emergency preparedness and PKD, and not just looking at patients, say, who might be on dialysis or post-transplant, but also, what happens to a couple if they are going through IVF or IVF with the genetic testing. And a blizzard hits, and for whatever reason they lose power or they can't get to the clinic where they've been going.
Yeah.
Are there any recommendations in that case?
Yeah, actually I think it's a national requirement to have a embryology lab that's accredited. You have to have an emergency preparedness program for if like a natural disaster were to hit, and how you're going to manage both the embryos that you've stored, the eggs that you've stored, the sperm that you've stored, and also your patients, and where you're going to move their data, their files, their the clinic activities, things like that. So every clinic has a standard operating procedure for that contingency. I mean, it's probably beyond the scope of our presentation today, but
Yeah,
I
yeah.
wouldn't worry about that as much maybe here in Canada, because of kind of the standards. I will tell you, in the States, this is a huge issue. Like in California specifically, they've had to activate their emergency preparedness programs many times in the last 5 years. Wildfires, mudslides, stuff like that. We just don't run into that stuff quite as often here. But yeah, I mean, it exists.
Awesome. Thank you so much.
Right.
Well, we're very close to our time, and I don't see any other questions, so I just would like to say thank you one last time to you, Dr. Motamedi, for sharing this information. I know it's questions that we often get here at the foundation from parents looking to start a family and potentially have children without PKD. And so we really appreciate your experience in answering these questions for us.
Yeah, of course, my pleasure. And if anybody wants to reach out, I can see anybody in Ontario. You can get an appointment to see me through my Instagram link. Also, you can just email me directly. We'll take care of you. Yeah, even if you just need directions, I'm happy to field any questions by email.
Awesome. Well, thank you so much. We really appreciate it.
All right.
And goodbye, goodbye, everyone.
Bye.